You're with me, Jessica Revel, on the video podcast Prisoner of the Mind. This broadcast is about mental health, mental illness, and suicide, and it was inspired by the death of my son Gregory in 2020 by suicide. He was an autistic man who struggled with mental illness. And I'm very, very grateful to have with me today Professor David Jobes from Catholic University of America, who's been involved in suicide prevention across his career. He's Associate Director of Clinical Training and the Director of the Suicide Prevention Lab, and has nearly, 9,000 citations across your career. It's a lot. And I want to talk to you today about Aeschi, which was it's kind of a movement in changing the narrative with people who have a suicide crisis, have suicidal gestures and ideation, and a way for clinicians to speak with these people differently. So let's just talk about the baseline of what you're moving away from. So what is the sort of the current clinical approach in many practitioners' methods to talk to people who have suicidal ideation?
Well, thanks for having me, Jessica. I would say, the prevailing model in the US and around the world is to think of suicide as a symptom of a major mental disorder like depression. And that's actually really off the mark. If 130 Americans die by midnight tonight in the US, only about 40 or 50 of them will have diagnosable major depressive disorder. So, and then we've got millions of people with depression who have no suicidal thoughts. So really what the research shows is that independent of the diagnosis, if you conduct assessment and treatment and focus on suicidal ideation and behaviors, you actually make progress. But if you're focused on depression or schizophrenia or bipolar disorder, and that's the focus of your treatment, it may not reduce suicidal ideation and attempt behaviors. And a lot of people just don't know that.
Yeah, so you're saying like suicide's its own thing. It's almost like it needs a separate diagnostic category.
And that's being considered. In the US, our DSM, which is not my favorite, I use the ICD, but
that's the Diagnostic and Statistical Manual.
The diagnostic manual that's used in the United States. There has been serious entertainment of a suicide-specific diagnosis. And cynically, if I'm a clinical psychologist and I have a practice, if I have a patient that's suicidal, I don't get reimbursed by insurance plans if I don't give them a diagnosis, and there is no diagnosis for suicide. So I would have to get another diagnosis and then make reference to suicide. So it's kind of a kooky system. But what I guess what I want your audience to know is that from an evidence-based standpoint, hospitalization is probably not that helpful for a lot of people that are suicidal. Medications aren't that helpful. What really is helpful are suicide-focused interventions that focus on ideation and behavior.
Okay, so explain what a suicidal specific intervention would involve.
Well, there's a handful of ones that have been well studied and replicated, including one developed in my lab. It mostly involves educating the patient to how they get in highly dysregulated, agitated, impulsive states. And what that means is that oftentimes when any of us get upset, sort of our inner brain, the limbic system, which is right in the center of our cranium, it gets activated, and it's a very old part of the brain. And it's often referred to as the fight or flight. It is the body's way of mobilizing if the saber tooth is coming after you. And it's really handy to have if you're in an emergency crisis situation. But the thing that's really problematic is that this part of the brain, the frontal cortex, which is the most evolved part of the brain, basically turns off when the limbic system gets activated. So a lot of what I would say that proven interventions do, Jessica, is they teach the patient that I'm getting into what Aaron Beck referred to as a suicidal mode, where I'm upset, I'm behaviorally dysregulated, I am having terrible thoughts, and I'm in this state, and this part of my brain is now offline. So a lot of the effective interventions help teach the patient that I'm heading in this direction. Let me do things that re-engage this part of the brain to down-regulate this older part of the brain that gets us in trouble, basically.
Mm. And
so that's a very broad, but I mean, I think that really cuts across a lot of the proven interventions, is they really teach us how we can sort of engage this really critical part of the brain to help us get in a calmer, more focused and rational state.
And part of the way that this Aeschi method does that is through storytelling. So how does storytelling factor in helping people who are feeling suicidal?
Yeah, I mean, essentially what I was trained in was you do an interview where you're asking about a lot of symptoms. And the Aeschi approach was really meant to turn that on its head. And we would just say to the patient, tell me about being suicidal, or tell me about your attempt, and just let them talk. So that's referred to as a narrative approach. That's where somebody tells the story of their attempt, or tells the story of their struggle. And the clinician just shuts up and listens. And that in and of itself, we think, is a very therapeutic experience, a therapeutic assessment. And then when we take that route, the adversarial nature that we oftentimes find between clinicians and patients around this issue. Have you thought about suicide? Yes, I have. Well, you can't kill yourself. Oh, yes, I can. Actually, no, you can't. And I'll call the police. And no, you won't. Yes, I will. That is counter-therapeutic, right? I mean, everything about that engagement is adversarial. But if I engage an approach where I'm asking you to tell your story, and I'm not judging you, I'm not knitting my brow, I'm not wagging my finger, I'm actually validating your experience and reflecting on it, I'm empathic, then there's much more of a chance of us being aligned and having a better alliance. And with a good clinical alliance, good things happen.
Yeah, and that goes way back to the concept of congruence, the humanist concept of congruence and trust. When we look at the way physicians are trained versus psychologists, it's quite different. And I think that there's often an imperative in their performance indicators to fix things and to control situations. And I wonder if this would be a bit of a stretch for them because they're used to quite a different speed.
Yeah, it's actually pretty interesting that you raised this. I'm reading a book right now called Desperate Remedies, and it's a book about psychiatry's turbulent quest to cure mental illness. And it's a fascinating read because it dates back to medieval times when the idea of someone wanting to kill themselves was an act against God. Mm. And the Latin term is non compos mentis, which means that, not of right mind. And so they would actually, the need of a paternal or doctorly presence to control them. And so many of the early interventions were interventions meant to control somebody and to bind them literally, or lock them up, or put them in a inpatient setting. And that leaves a mark, that has a legacy that brings us right up to the present day, where, in both of our countries, there's a common notion that a person who's suicidal belongs in a hospital, even though those hospital stays, at least in the US, are, about a matter of days. And we know from the research that when they get out of the hospital, they're actually at increased risk. So, you have to think that the medical model is kind of not working well with this issue. And so that's where the Aeschi approach, or the kind of interventions that I'm involved with, really take a very different approach. And even to the point where I would say, I've been at this for 40 years, I'm much less focused on suicide prevention, and I'm more focused on suicidal suffering. Because in the United States, that's 15 million people. Adults and teenagers, that's a lot of people. It's a 12th leading cause of death for us. We got 1.2 attempters, but 15 million people is a massive iceberg. That's our suicide problem. And if we were better, Jessica, at identifying people who have suicidal thoughts and identifying them and treating them in an empathic, collaborative, validating way, fewer, I would argue, go on to make attempts. Fewer still will go on to die by suicide. But that's a very different model.
It almost sounds like something that needs to be rolled out not only to clinicians, but to the community. a lot of people who are mentally ill, the first encounters they have would be with authority figures like the police or people in the community. And so much of the prevention, work relies on people in the community, which is troubling in a way because they may not be equipped emotionally to deal with their own triggers when encountering such people.
Yeah, they almost always are not. And so we have in the United States, our lifeline is now moved to a 3-digit number, 988. And what's happening is that we're seeing that we now have safety checks or these euphemisms for basically a police officer showing up with a gun on their hip. If you're a person of color, that's not, in this country, that is not a welcome. And there are many anecdotes of police killing people who are suicidal when they're sent there to do a safety check or to be helpful. And the cops I know don't like it. And so one of the really exciting developments in this country is looking at stabilization models that don't involve police officers, where a social worker or mobile response team or even technology, which we'll talk about later, might be the first touch with law enforcement in the background, and sort of playing a backup role. And there's retreat centers, there's respite models. There's something called the Hope Institute, which I'm really keen on in Perrysburg, Ohio, where all the clinicians are trained either in my intervention, which handles suicidal ideation, or something called dialectical behavior therapy. And that's all they do. And they give people next day appointments. They see people who are highly distressed for up to 4 times a week. And they're stabilizing adults in 6 weeks and kids in 5.2 weeks. So I love models like that are short of hospitalization, that avoid the emergency department, because that's probably not the best place for people that are suicidal. And so it works in this sort of lethal space between being in crisis and getting outpatient care. And I don't know about Oz, but in my country, getting outpatient care, there's always wait lists, weeks, even months.
Yeah.
And the care is not going to be suicide specific and evidence based. So we've got a real problem. And 988, which is great, is also kind of outing the fact that we don't have a safety net or a way to sort of work with this.
No, I think it's such a misunderstood thing in the public. Often at the end of a story about mental health, they'll put up a note at the end here and say, if any of these things have raised issues for you, call Lifeline. But what people don't know is Lifeline's just simply and they do very well, to organize you into either a dangerous category or a not dangerous category, and then you're sent to an emergency room where really not very much happens. And people are even, I know of one of my peers who's lost a child, that they went to a hospital in Victoria in Australia, and they sat with their child in the emergency room for 6 hours and then were told, there's nobody here to treat you, you should go home. Now, you would never say that to a cardiac patient, but you.
No, you wouldn't.
Also, I want to also talk about the foundation of attitudes to people with mental health issues within, especially the psychiatric community, because sometimes it appears to me that there's a notion that it is perceived as a weakness of personality or character. I have heard many stories of one lady I know who went into the hospital who had had an overdose, and the nurse shouted at her, "You stupid woman, don't you realize that you have probably messed up your kidney and liver function for life?" That's not something that any other category of illness would probably hear.
No, and that's why looping back to the Aeschi movement, it was when we first started in 2000, it was a pretty radical idea, because many of these patients, and these are people now with lived experience who are coming out of the woodwork saying, we have had terrible experiences with conventional mental health care, and we're not going to take it anymore. And around the world, especially in the United States, we've got very vocal people who have told stories just like that. I was on a webinar with Marshall Linehan, who's a developer of dialectical behavior therapy, and we were talking about our interventions. And we had this woman, Diane Cortez Llanes, who's a person with lived experience and made 4 attempts and had been hospitalized multiple times. And she told the story of sitting with her doctor in a 4-day hospital stay for 20 minutes, who interviewed her and never once made eye contact with her before he walked out of the room.
Yeah.
Just horrible treatment that no one deserves, let alone somebody who's vulnerable or traumatized. So, we've really got a cultural challenge where we've got a status quo that the pharmacological, companies are bought into, that, large medical centers are bought into. They've got to keep their beds filled to pay the bills, but it doesn't work. It's broken. And so I'm not campaigning against medication or against hospitals. I'm just saying the care must become much more suicide focused and evidence-based, not just because we've always done it this way. That is no justification for practices that probably make things worse versus better.
Getting into the narrative itself, when using the Aeschi method, you are interviewing somebody who is suicidal. What is a best practice approach to that narrative? What do you look to achieve?
Yeah, honestly, I don't mean to be glib, but to shut up and get out of the way. To really make it okay for this person to tell their story, and to not be looking at the phone to call the police. I mean, we have a new line of research in my lab where we're talking to people with lived experience, and through very careful informed consent, we say, this is not a therapeutic intervention. We have resources for you, but we are just interested in hearing your perspective on life, on death, on a life worth living, a post-suicidal life. And we've done 5 of these in-depth interviews. They run about an hour and a half, and they're mind-blowing because, Jessica, they can be so candid because we're just going to listen, and we're not going to react, and we're not going to judge, and we're not going to freak out and call the police. And so it's just been very moving to hear people tell their story. And we know that narrative interview is therapeutic in and of itself. So, in terms of best practices, I would say clinicians need to be I teach an interview course where drive my students crazy, where I basically shut up, get out of the way, and listen. And these are clever doctoral students who battled their way into a clinical psych program, and they're good at being clever and obsessive and asking questions. And I said, all the things that got you into graduate school are going to betray you when you're trying to form a relationship with a patient, because your humanity is the thing that's going to count. So in my intervention CAMS, the Collaborative Assessment Management for Suicidality, the 4 pillars are empathy, collaboration, honesty, and being focused on suicide. And in CAMS, we ask the patient, what makes you suicidal? And then they tell us, and that's what we target and treat in the intervention. So we don't care about depression. And if they say, well, it's my depression, we'll say, what are you depressed about? And they never say a lack of serotonin at the synaptic cluster of my neurons, my prefrontal cortex. They say, my girlfriend dumped me. I hate my job. I can't get a job. I hate myself, my trauma, combat in Afghanistan. Those are all problems that we call drivers that we know how to treat. So I'm just saying that, there's a very different way of engaging with someone who struggles in this way, where their experience can be honored, validated, and you can engage them such that they can shift their take that this is the only thing I can do to deal with this profound suffering. And that's all it takes to save lives. I mean, I don't mean to sound simplistic, but it doesn't have to be moving a mountain. Sometimes it's just that you could look at this just like this way. And that shift in looking at it could be enough to get you through a dark moment. And then you could learn skills and ways, to make your life more worth living over time.
You also refer to meaning making in this narrative. What do you mean by that?
Well, we're learning about that because I sort of had the notion that everybody would want to not be suicidal. And we're talking to people with experience who say, I resent you wanting to take my suicide away from me. And we're like, tell us more about that. Well, I live knowing that I have suicide in my back pocket. It's the way I live. And who are you Mr. Smart doctor, professor, to tell me that I can't have that. I've never been suicidal. Who am I? I studied it for a long time, but I've never personally known what it's like. So I'm really I'm 64. I've been at this for a long time. I really want to have an open mind to thinking about this major cause of suffering, 15 million Americans. And to sort of like turn over the apple cart and think about this all together differently. So there are some people where we've been interviewing and saying, what would make your life worth living? What would give you purpose and meaning? Because that's what I like. But not all people that we're talking to aspire to that. It's really interesting. Some people really do. And I would say so far out of the interviews we've done a half dozen interviews. Half of them have been very preoccupied with giving back, with helping other people, with having, plans and goals and purpose and meaning. But it's not for everybody. And so I'm trying to not be the guy that knows is a know-it-all to tell everybody what they're supposed to do. And how do I know that? I mean, I know a lot, but I don't know that.
Take the shooting out of it. And as I think a very, very big shift from a clinician's perspective to embrace suicidality as a safety net from the client's perspective, that may eventually change. But for now, it's the thing that they have that they feel is protective of them. As I say, most suicidal people don't want to die. They want to leave their pain. And that is the way of leaving extraordinary.
And I think within the culture of contemporary conventional practice, we're going to rip this away from you and leave this gaping hole.
Yeah.
And you need something in its place. And so I can think of things that can go in its place, but you don't rip it away prematurely. No. It's not therapeutic.
And that would undermine the trust from the beginning, wouldn't it? And if you're trying to establish trust, they say, this is important to me, and you negate that, then the trust is broken.
Yeah, in fact, what I would say in the CAMS model, we're resolving suicide risk in 6 to 8 sessions, but we're not eradicating every vestige of it. We're instead focused on turning a corner and being able to manage the thoughts and feelings. And managing thoughts and feelings and being stable is really actually quite important than exorcising this out of you. All things being equal, if I could exorcise it out of them, I would do that. But what we're seeing in the clinical trials, Jessica, is that we can just change this enough that this person can live with themselves differently. I'll give you a great anecdote. We did a study in Switzerland focused on reasons for living and reasons for dying. And we thought that reasons for living in our first session would be very predictive of what would happen later as a protective factor. And we did the study, and reasons for living did nothing because the patient was always focused about reasons for dying. But and I know that clinicians are going to say, oh, but what about your kids? What about your husband? What about all the people in your class that you teach? What are they going to do without you? It's a clinician variable. It's not a patient variable for people who are acutely suicidal. So what we've shifted now in our training models, we still ask about it, but we dial into the reasons for dying. And as they make progress, then we bring in reasons for living. Plans, goals, hope for the future, purpose and meaning. And one of the biggest findings of the CAMS intervention is that it increases hope and decreases hopelessness. And that's a great finding because what we're doing is we're evolving the patient's relationship to suicide. And that's why this new line of research, I coined this notion of a post-suicidal life and thought I knew all about it until we started talking to people with lived experience. And I know something about it, but I'm learning a lot more from people who actually are in that space.
And I suppose that's because you can open yourself up to seeing from their perspective. You also write about mentalizing in terms of helping people. Can you explain a little bit about the concept of mentalizing?
Yeah, mentalizing is a really great construct. It's developed by these guys in the UK. And it's really like seeing the tree and not the forest. that you are failing to look at yourself from the outside. So if I'm properly mentalizing, I'm able to look at myself from the outside, and I'm able to look at other people from the inside. So it's a perspective shift. And a big thing in effective interventions like CAMS is that we get the patient to mentalize. We get them to look at themselves from the outside. The clinician looks at them from the inside, and they cultivate a different skill set. And that's what good psychotherapy or mental health care is. It's perspective shifting, right? I mean, there's biology and there's skills and behaviors and all that kind of stuff, but really at its best, especially in life-saving work, it's a shifting perspective that we carefully cultivate and don't force on the patient, but sort of nurture along over the course of care.
Yeah, and getting this into clinical training, getting this into
It's very hard.
hospitals, how are you managing to do that?
It's very hard. In the United States, we have a study. So randomized controlled trials are the way that you prove something works. And we've seen this with the COVID-19 vaccine, right? So there are different phases, but it's a basic experiment that shows that this medication stops, viral transmission. Same thing goes for clinical trials in mental health care. There are 6 clinical trials of CAMS. Nobody's ever heard of it. We have 1 clinical trial for clozapine, which is an atypical antipsychotic, and the FDA approved it as a suicide preventive agent. 1 RCT, no replication. My intervention has been replicated 6 times and 2 meta-analyses. So it's just crazy. It's not about the data. It's about culture. It's about control. Frankly, it's about politics and money. I hate to sound conspiratorial, but I really do think that there are large powers around the world that like the status quo, that like a custodial model, that like a medical model, keeps the beds full, keeps the doctors in a position of power and authority, but it's not necessarily good for the patients. So that's where we developed a training company, and we've trained 30,000 clinicians, which sounds like a lot, but it's a drop in the bucket. 15 million Americans with serious thoughts of suicide. So you have to go into business. And of course, if it's business, then it's unseemly and you're making money and all that. But that's how you try to get people trained. And we've trained a lot of people, and we've trained a lot in Australia. Actually, we've done probably, I don't know, a dozen trainings, and I've been there a few different times. But it's really hard because we have decades and decades of this zeitgeist, this medical model approach, and where people think, oh, you just treat the depression, just give them an antidepressant and they're good to go. And that actually the antidepressants probably increase the risk more than decrease it. So it's a complete culture conventional way of thinking about things that you can't overturn overnight, frankly.
Right, and I think effective solutions are often more time consuming. You have to invest more training and more money, and sometimes that's not received well by the powers that be. We recently there was recently a story in the news here about how there was a $130 million package, and they were going to train as part of it 200,000 parents in suicide prevention. Well, as about 80% of the cases don't show any signs, could that good money be devoted to bridging that gap, that first 30 days out of hospital, where people are most at risk? We only have 3,700 odd psychiatrists in this whole country. Can we fast track some people into psychiatry? There's things that are going to be a lot more effective than that. But going into your conspiratorial theory, I often call this the passive genocide. That they're expensive and they kind of get lost by neglect a lot of the time. And if you have the double whammy of being, say, a minority group or have cognitive impairment and you're suicidal, the risk of your dying is so much higher, and the interventions are simply not there.
Yeah. I'm not completely grim and discouraged. I think some good things are happening. The research in clinical suicidology is blowing up. We put on a conference, the Suicide Research Symposium, that we threw together in a matter of months. and focused on students and young investigators. And we got 130 abstracts, and we are doing it again. We got 300 abstracts, and we're getting, it's free, so that helps. But I mean, the interest level is just through the roof. So there are really exciting things that are happening, and the research, the NIMH, for example, here in my country, that funds a lot of research.
The
There's been a
National
big,
Institute of Mental Health, yeah?
that's right, the National Institute of Mental Health has shifted a lot of funding dollars towards suicide prevention. I've got 4 NIMH funded trials right now, in our intervention. So, things are changing, and I don't mean to be sort of gloom and doom about it, but as you've acknowledged, we've got like a way that things have always been done that's hard to change, and it's going to take time. But I do see change coming, and I do see promise in the future.
That's great. Your approach reminds me of a Spanish proverb, and forgive me my pronunciation because I never learned Spanish. Cada cabeza es un mundo. Each head is a world. And I think that the Aeschi approach really treats respectfully each head as a world, and those worlds can be very complex. So I thank you very much for talking about this today. And if you are watching and you are struggling, I believe you. And in the words of my son, I want you to know that you matter.